Hello, ladies and gentlemen. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. We are 17 in number. If you're joining for the first time, this is a platform that brings together healthcare professionals from Cameroon and who are spread across the world from more than 36 countries. We've been here for the past 3 years. We've never skipped a session, and this is the number 103rd or fourth session, if my memory is correct, Brian. And we are really thrilled. We meet every fortnight to discuss on healthcare issues that affect our country and to seek for ways in which we can contribute in improving the healthcare system in Cameroon. And so if this is your first time, you're welcome. I'll hand over to Brian. Hello, Brian.
Yeah, hi, Elvis. It's always great to see you. Last week we had a really phenomenal, last session we had a really phenomenal speaker, really engaging conversation on sickle cell disease. As you know, on the 19th of June, we were all reminiscing the World Sickle Cell Day. So I think it was a great opportunity for us to look at the progress that has been made in the fight against sickle cell, the need for awareness, both locally in our own in our own country and also globally, what the issues around sickle cell, the challenges around sickle cell management was. So I think Dr. Matt Polo did a really phenomenal job, and it was really wonderful to hear about some of the contributions that she's making in her organization to advance or to increase awareness for sickle cell disease. And I know last session as well, Dr. Mono talked to us a little bit about some of the new therapeutic targets that were in the pipeline, because as you know, the American Society of Hematology too has had its annual meeting, and they discussed some of the new innovations that were happening in the space as well. So I thought that was a really phenomenal discussion, and really thrilled for today's session as well. So thanks a lot, Elvis. It's always great to see you, and welcome also to our chair, Dr. Mono.
Yeah, thank you very much, Brian. I'm looking forward to this session today, and it's one of those things we don't talk about very much, and I think we have an expert in the room. Going back to sickle cell, it's one of those diseases that is purely very, still affects more people who are underprivileged, even here in the US, meaning those who do not have access to healthcare. And every day I still see Black children getting mismanaged in a purely white society too. And there has been a big push in order for us to help these kids out by educating health professionals, including doctors, including nurses, including scientists, by engaging financially in order to develop therapeutics for these kids. And what was very interesting about Sandrine's presentation was trying to get out of the clinical environment and talk about this like a social phenomena and see how we can get to solve this problem, even with the limited resources that we have back home. So that was very thrilling. Getting to talk about development in sickle cell, we do have, the past 5 years has been the best years of sickle cell, meaning the best really. We've had development of 3 new FDA-approved drugs in addition to hydroxyurea. And we've had genetic editing, which is the first disease really that we are able to approve a drug really for gene editing and CRISPR technology and the lentivirus technology. We do transplant, but all these things are very expensive when it comes to helping children back in Africa. So her presentation gave us light into what we can do in the future. So Brian, that was my takeaway, but I'm looking forward to you introducing our wonderful speaker for today and for us getting to talk about something else.
Yeah, thanks a lot, Mono. And today's session really is we're going to talk. The Dr. Fatima Kempo is going to talk to us a little bit about supply chain management in Cameroon and some of the challenges that underpins that as well. Really, how we move from strategic procurement to last mile delivery. And one of the biggest challenges, Dr. Mono, is really around access. And we've discussed a little bit more about this access to some of the innovations that's being developed and all of the innovations that exist in the pipeline, and how do we get this to the populations that really need them. And I hope, Dr. Elvis, as well, I hope that with the work that you do with clinical trials and that, because we do need data to make these decisions and these informed decisions, we really need evidence-based data to drive where we are locating our resources. So I think there's a great room for opportunity there. So I definitely looking forward to the discussions with the exchange today with Dr. Fatima as well. But I also wanted to invite you, Elvis, maybe to hear a little bit your thoughts when you reflect around supply chain management and the challenges that we face in Africa. What are some of the things that really occur to you, and how do you think?
You just said it, Brian, data, availability of data. When we don't have data, we cannot even know what is needed. I spoke to someone back in Cameroon who also is involved in supply chain, and I asked a simple question to just prepare my thoughts around this subject for today. And I was like, what is it that you'd consider when you are trying to do quantification for commodities before you even place order to see that it gets to the last mile communities? And I got from him that one of the consideration is they first of all analyze data on uptake from all the different health centers. And I'm like, okay, if you're analyzing data on uptake to know exactly what is needed, it means if a health center in Miseje is able to use just 2 boxes of rapid diagnostic tests because that is what they have, that will be reported as their uptake, and the next year you will send them just 2. So then what happens to their need in terms of supply chain? So it's a topic I really want to learn a lot. Today, I'm really going to be learning because I know very little about supply chain, but I think there is a lot that needs to be done.
Yeah, thanks a lot, Elvis, for your remarks. I totally resonate with those. And welcome to everybody. I hope all the questions and thoughts that you have, you can just hold them till the end of Dr. Fatima's presentation, and hope we can have an opportunity today to brainstorm around solutions for some of the challenges that we do have in Cameroon. We are hopeful that at the end of this session today, we will come up with a brief and succinct report that we hope can be helpful in addressing some of the deficiencies that we have in our own local context. So I'm going to move on to introduce our speaker for today. I feel deeply honored to introduce Dr. Kempo Fatima. It's a great honor to have Dr. Fatima. Most of you in Cameroon may recognize her or know her because she's a very prolific writer and a very prolific speaker and leader. She was also recently nominated as one of the Forbes list in Africa 30 under 30 really leadership awards for the 2022. So she's a dynamic public health pharmacist. She obtained her pharmacy degree from the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé. She's done a lot of work around supply chain management for critical health programs in Cameroon, and she has a lot of experience in that specific domain. She's a Fulbright scholar, so at the prestigious Fulbright Scholar program, and she did some of her work when she was in the United States doing her Fulbright Scholars program, really revolved around supply chain management, strategic procurement, strategic quantification, inventory management, and last mile delivery of medication, some of the things that we've been discussed about. She recently obtained her Masters of Public Health from the renowned institute, Johns Hopkins University, the Bloomberg School of Medicine, School of Public Health, and really excelled in that program as well. She's the founder of the organization called Body Talk International, which has been working to empower women across Africa on issues around health education. So she's been a very prolific, very active community engager, really engaging the community to advance public health for the good of everyone. So I'm really thrilled, Dr. Mono, that we have Dr. Fatima Kempo. I think we're going to learn a lot from her presentation today, and learn a lot from her presentation today, and also have an opportunity to take on some of these lessons and see how these lessons can be redirected, not only for us in Africa, in Cameroon, but also more broadly across the African continent. So thrilled to welcome Dr. Fatima. Dr. Fatima, welcome, and the floor is yours.
Hello, everyone. Good afternoon from my corner. Thank you for the honor of speaking here. I've been following this initiative since 2020 when I was on lockdown with COVID. So I remember the very first few editions. Thank you, Dr. Mono, for keeping this going despite all the challenges. It's my pleasure to be here. I wasn't quite sure. I know this is a health professional platform, but supply chain is, as you said, kind of a topic that a lot of people are not well versed in. So I was trying to decide how I wanted to structure this presentation, and I decided that I will keep it as a general overview and narrow it down towards, literally start very broadly and narrow it down towards the end, but keep it as general as possible, just to give the general theme so people who have never considered this as health workers in our little spheres, whether we're pharmacists or nurses or lab technicians or whatever work that we are doing within the health system, or even administrators, to just give us an idea of how it fits into the whole health system itself, and then talk about the specific challenges that I observed in Cameroon, and maybe not just Cameroon, it's kind of a cross-cutting challenge that a lot of other countries are facing. And then if we have time, I know there's not a lot of time, if we have time, since we want to also talk about solutions, I put in a few solutions, but there's a whole other short presentation that was a detailed presentation on a current solution that has been applied. Hopefully we don't get to that because it's really detailed, but I wanted to keep it in a broad scope so we could have just experience sharing about it. So before I start to share my screen, and on any of those on this call, if you're currently working in Cameroon or have worked in Cameroon, can you just raise your hand? Or just use a reaction, let me see. Yeah, I might not be seeing everyone. Great. If you are currently working in Cameroon, raise your hand if you're working in a health center. Health center, regional hospital, district hospital, whatever. Okay, yeah, quite a few. So let me go ahead to share my screen and then we can begin. Just give me a moment. Okay, can you see my screen? Okay,
yes,
great.
we can. Yeah.
Okay. So my presentation today is to give a general overview of supply chain management with a focus on Cameroon. And the plan is straightforward. It's just to make sure you understand why health supply chain is and should be a big deal. I'm not going to be any more detailed than that. Can someone just unmute themselves and tell me this? What do this group of pictures have in common? If you can identify the items or you just see boxes, what do you see when you see this group of pictures? Anyone? I will just call a random person. Dr. Allen, I have seen the name I recognize, so.
I'm not sure about the question. What I see in common, I see boxes, probably stored in a warehouse. Yeah, that's all I see.
Okay. And that's what it's to be seen. But just what I wanted to point out here, that what this group of boxes have in common, they're all stored in different places, but they all represent different public health programs. I wish my pointer, let me go pointer. Yeah. So we have nutrition, we have sexual reproductive health, we have vaccines. So just tell you that there's a saying in health management that no product, no program. So a lot of us might not be directly working with products every day in our healthcare careers or in the jobs that we do, but somehow, some way, products are involved in whatever you're doing, whether you're a surgeon or whatever role that you're playing. And this is just a quote from an old WHO report that was still during the Millennium Development Goals, but I think it's still true up to now, that although we can treat most diseases using inexpensive techniques, and these techniques are known, the problem that we have lies elsewhere. It consists in providing personnel, medicines, vaccines, and information to those in need at an appropriate time, in sufficient quantity, and in a reliable and sustainable manner at a cost that is acceptable. And that's the bane of any health manager's challenge. And you see how supply chain kind of cuts across all of these themes. So what is supply chain management? Literally, it's the operational engine of any healthcare system. And not just any healthcare system, any healthcare pharmaceutical system. And it is all of the processes that lead a product to move from development to the last user. Whether this product is a medicine, it's a vaccine, it's a medical equipment, it's even protective gear. And logistics activities or supply chain activities are the operational component of all of this. So just to summarize, it includes all of these activities, including coordination and collaboration with different partners. And it integrates supply and demand. Is there a need? Yes. There's a need for healthcare. There's a need for materials. And how do we deliver this need? And as I said earlier, before starting this presentation, the goal of any public health program in general is to ensure that there are good healthcare outcomes for patients. So when there is no product, there can not be a program, because most, Dr. Monono, you raised your hand.
No, that's an error. Sorry, please.
Okay. So the goal of any supply chain is really bigger than making sure products get where they need to go. We said it has to be at acceptable cost. It has to be sustainable. It has to improve health outcomes. That is the ultimate measure. The ultimate measure is not if products got where they needed to go. So supply chains are integrated into any country's healthcare system. And they increase program impact. When we're talking about public health programs in Cameroon, I think the main public health programs we have right now are HIV, malaria, tuberculosis, and then we had emergency response programs for COVID-19, for cholera. And I think even measles right now is receiving a resurgence. And then EPI or all the vaccine programs are grouped under one program. And lastly, there's the non-communicable diseases, which also has a lot of public health attention. But all of this, the aim is to improve their impact, enhance the quality of care, and improve cost effectiveness. And when it comes to a public health supply chain, improving health outcomes can be achieved with the 6 rights: the right products, the right quantities, and the right conditions, delivered to the right place, at the right time for the right cost. This is the utopia of supply chain management, but we'll see, and we all know in our own experience that this is usually not the case. Sometimes one is sacrificed for the other, but the job of any supply chain manager or any healthcare manager is to try to find the right balance. So this image, I'm just trying to illustrate where supply chain fits into the health system and fits into the pharmaceutical system in general. So the health system is the overarching system of any country. And whether it's with governance and policies, human resources, service delivery, information and financing, this all form the part of the health system. Now, one thing people don't know is that the pharmaceutical system seems like a subsystem of the health system, but it's actually a system of its own, because it still needs all of these resources, whether it's about governance or human resources, to function. And then where supply chain falls is under the service delivery arm of the health system. And without information, without finances, without human resources, even service delivery itself cannot work. So they are all interconnected and interrelated. But the main aim, or what we call last mile delivery in supply chain terms, is that it should get to the user and it should get to the community. And this depends on access. Is it available? Is it accessible? Is it affordable? Something like the 6 rights, just stated differently. I don't want to explain this. This is just a simplified way of showing the pharmaceutical system with a bit more detail, saying that while our desired health outcomes are the last part of any system, what goes into it or the short-term outcomes is access. Do we have it? Can people get it and use? And adding more details to governance, for example, under governance, we have laws, we have policies, we have regulatory systems, and there are other elements that can add on to financing of human resources, such as innovation, research and development, and manufacturing. So we know that any supply chain manager's role, no matter your title, especially in Cameroon, I think those of us who have worked in district hospitals or small health centers, you know that sometimes you can be the head of the health center, but at the end of the day, you're wearing multiple caps. You're the person who has to manage the small pharmacy. You're the person who has to order products. You're the person who has to do all of these things. So sometimes the supply chain manager is not a designated person, but it's just an additional role that a staff has to take on. This is a classic diagram that I want us to understand because it says what should be, or the general secret that a lot of countries follow when it comes to pharmaceutical supply. I will do this and then I'll show you what Cameroon's system kind of looks like, or what the diagram is that we have been using. And that's where we start identifying where the gaps are and things like that. So generally in any well-functioning system, what happens or where things start is that this is the beginning. There might even be a bigger beginning. There might be an identification of a need. And it starts with research. Research leads to clinical trials, manufacturing. A lot of us work in this space. And after clinical trials, which take years and years, sometimes can go up to 20 years, and then manufacturing and registration of the product, and it's accepted into the market. There is quality control, there is market surveillance, or what we call pharmacovigilance after the product is placed on the market. And then when it comes to public health or the product getting to the last people who need it, it starts with financing. Every country says, okay, how much do I have to spend on products? Or every health system says, how much do I have to spend on products? What kind of products do I need? We set priorities, you set criteria, you choose your products. And then you go to quantification. These are the kind of products that I need. How many do I need for what period? And quantification is usually closely followed by procurement. Procurement is the act of actually getting those products, following international standards and specific criteria. This is usually where a lot of supply chain activities start with procurement quantification. And then it moves on to I have the product, it's in the country. How do I store it? When I'm done storing it, how do I distribute it? And then it comes right down to our little health centers, into our regional hospitals. What prescribing processes are there? What are the protocols for national protocols or for regional protocols for treating any particular disease? And then we go on to dispensing and sale, use, and then back to pharmacovigilance, which comes up to the top. Normally, I prefer this diagram as a cycle because the things rotate. But I wanted to show you where supply chain falls and what the general structure is like. And now, to just take out the area that falls on the supply chain and develop it a bit, when we start with product selection, and this is where we're going to talk a bit about the general practice, and then I'll start citing some of the things that happens in Cameroon. The logistics cycle is the supply chain area of the previous diagram that I showed, and usually it starts with product selection. Here, I'll be speaking mostly about public health programs. We know that with essential medicines and national pharmaceutical management, it's a bit different, but this presentation is trying to get a bit more public health programs, which are more complex, honestly, to explain and to understand how they function. For example, if I were to ask someone in the chat, how do you think, how do you think malaria medicines, the under 5 malaria medicines which are given for free in the country, how do you think they are chosen? Who gets to choose which malaria medicines should be bought in bulk for the under 5 population? It's an open question. Anyone could either leave it in the chat, or if you think you have an idea of how do you think we choose malaria medicines, for example, for our public health programs. Is there anyone who wants to try? Frank?
Yeah, Frank. Yeah.
Mhm.
Yeah, you're muted. Sorry. You're muted. Can you unmute your mic? Yes.
Okay. Do you hear me now?
Yes, we can.
Okay. Please, can I speak in French?
Yes,
Bien
bien
sûr.
sûr.
Ok, d'accord. Je pense que c'est parce que le paludisme, c'est la principale maladie, c'est la principale cause, je crois, de mort peut-être au niveau des enfants, des nouveau-nés, comme elle est endémique, quoi. Et je crois que c'est la raison pour laquelle c'est l'un des, comment on dit, c'est la catégorie des médicaments qui fait partie des priorités pour notre gouvernement, quoi.
Ok, merci. Je vois encore deux mains. Je veux qu'une autre personne me donne. Joseph?
Yes, thank you very much for this insightful communication. Just to give a tips, even though I'm not really a malariologist, but I work with the AIDS program, so we collaborate together with the malaria team. And procurement for the malaria drug, for what I have seen so far, is generally through the CNAME mechanism. CNAME is our Central National d'Approvisionnement des médicaments essentiels. So they have this mechanism whereby procurement is done through the Global Fund mechanism. There's this database called Wambo. So Wambo is being used to place the various orders, be it for the malaria drugs or even the malarial essential diagnostics tests. So maybe that's just as an overview, as I'm saying. I look at it from a distance. Thank you.
Thank you. I won't take any more time. Thank you both for your answers. They touch on some aspects of it, but it was not exactly what I was asking. You talked about the procurement, which is great, but I was talking here about product selection. Procurement is when you're buying. Product selection is when you have to decide what to buy. And you've mentioned some of the things I'm going to touch on later. Big public health programs like the malaria program, deciding what to buy sometimes does not fall on the national government. You think the government of Cameroon will have more agency on deciding what to buy, but there's a lot of politics around it. It's a mixture of WHO standards and what the global fund says they will pay for versus what the country thinks they need. So product selection is I'm already highlighting for you some problems, but I don't want to focus on the problems here. I just want to show you how the cycle works and where things could go wrong. So first, we have to decide what we need at product selection, and then we have to quantify what we need. How do we quantify it? I think at the beginning of the conversation, we talked about data. We need data to estimate needs for the country, and we usually quantify for a certain period of time. It could be a year, it could be 2 years, it could be 3 years, depending on the program. And then that's when we go on to procurement, which is the finances system, and whether you're using an app to order, whether you're using a manufacturer that you have an agreement with, all of that is just more complex, but that's the system. And once it comes, how do you store it? Where do you store it? And lastly, how does it get to the last person in the last hospital in Ikiliwindi? I don't know. So I put this because I wanted to show that in emergencies, this process is not even as straightforward as our diagrams have explained. A lot of us here worked during the COVID-19 era, and we saw the chaos that was present. At the time of COVID-19, I was working as a regional pharmacist for the regional delegation of the Southwest, and I was part of the logistics team for the incident management system, which is the operational system that is set up to respond to public emergencies. And in this case, you're not just even thinking about all procurement or selection. Those are things that have already been predetermined. You're thinking about how to get things to the field as quick as possible. You're thinking about managing other teams. You're thinking about transportation, which is a thing that sometimes, if you're in your own health facility, you don't have to worry about. And you're thinking about communication, how to communicate, how to share data, and all of that. So we're going to be transitioning now to talk not just generally about supply chain management and its importance. We've laid that groundwork, but to look at Cameroon's pharmaceutical system and the supply chain challenges that it faces. And I put this question at the bottom here because it's a question that as health personnel, we always ask ourselves, which is better, predictability versus innovation? It's not a question I'll ask, but it's something to think about as we look through some of our challenges. So this is the pharmaceutical system in Cameroon. It's actually a very simplified version of it. The original one I had was really more complex, but I chose this one. I think this one is from a USAID document. Sorry, I didn't reference it. And it cuts down a lot of the extra stuff. But ideally, this is what we have. We have donors. There are a lot of them, depending on what program you're working on. We have imports, we have local distributors. Public health programs usually might not deal a lot with these aspects, but sometimes the government has to do procurement for the programs themselves, so they have to work with local distributors. We have CENAMI, which is like the central medical store, as one of my colleagues said. And then with public health programs, we might not deal a lot with wholesale distributors. Some of you would be familiar with some of them like Laborex, UB Pharm, who are the wholesale pharmaceutical suppliers. But we sometimes have to deal with faith-based organizations, even with public health programs, because they also manage HIV commodities. They also manage malaria commodities or tuberculosis treatment centers. Then we go to the regional funds for health promotion at the regional level who receive materials from CENAMI. If you notice here, normally the regional funds are supposed to receive materials directly from CENAMI with no crosses. I've told you this is the ideal document, but I've worked with the regional form and I've seen how materials can cross levels a lot of the time. Sometimes they leave from the donor straight to the regional store. During COVID, I had to receive materials from UNICEF directly. And sometimes because there's not this exact part, there's one thing that is not here, which is supposed to be here, the regional delegation of public health. The regional delegation of public health is normally not part of the pharmaceutical system, but during emergencies, it becomes an integral part of this system. When I worked at the delegation, our store had to receive all the COVID-19 materials for the region and cholera materials. We barely did not have a store, but we had to store tons of materials and find a way. I have pictures that I'll show you towards the end of this presentation. So you see that this is not a perfect diagram. This is what should be, not what is. And then we go down to our hospitals, our NGOs, our community-based organizations, especially with HIV management and things like that, and then the end user or the community. I brought this diagram back because I wanted to start highlighting the things that could go wrong, but I think I've already touched on some of them. So we'll break it down subsequently. Now, what could go wrong in Cameroon system? Off the top of my head, I'm sure a lot of you already have like 5 that could go wrong, but the first one that I like to put, and I think is very important, is that it's a system that did not create space for supply chain managers. And I'll say this as a pharmacist, that pharmacists are not logisticians. How many pharmacists are on this call?
Yeah, I do see that there are several, Dr. Fatima.
Yeah. So a lot of us pharmacists, for example, the government launched what we call, we say it in French is gestionnaire de stock, and then there's they created what they call the supply chain unit at every delegation. And the supply chain unit at every delegation is being headed by pharmacists. I think this was a valiant starting effort because honestly, when it comes to product management, you bear with me that pharmacists have a bit more familiarity with how to manage products than doctors because it's part of our training in school, even though it's not a core part of what we are called to do. But the government started this supply chain management unit, which was a great idea in my opinion, even though it has its faults. But they made pharmacists heads of all these units. And even in hospitals now, especially district hospitals, they are creating supply chain units. And the pharmacists themselves are made to be heads of this unit. The problem here is supply chain management, as you have seen some of the things I've shown you, what it entails. It's a very large scope of work. And a pharmacist's basic job description is already full. And we realize that a lot of pharmacists are now doing full-time logistician work and not enough of the pharmacy work, which is product quality control, which is counseling, which is therapeutic monitoring, which is all of that it entails. I know it's a call for more public health pharmacists, but in a country like Cameroon, where there are not even enough pharmacists to begin with, it begins to take a toll on the profession. And especially when you have to transition, say, from the delegation of public health as a public health pharmacist back to a hospital, sometimes you lose touch with some of those skills because you become clearly, we used to tease ourselves and say, a cartoon carrier. It's an important role, but it's a role that kind of drains on some of your more essential skills. So that's one thing I like to highlight. Poor governance cannot be overstated, especially when it comes to public health programs. Here, I'll break it down in terms of laws and policies that exist to manage public health programs. The three main public health programs for Cameroon do have their national plans, like there's a national HIV plan and things like that. But when you see how these programs are managed on the day-to-day, there is a lot that is deviant from those national plans. Those are beautiful documents that nobody follows at the end of the day. Poor organization and management of services, which just comes back to organization and the work and who has to do the work. And even in small health centers, you have nurses who at the same time have to manage the pharmacy, at the same time have to be the supply chain managers, at the same time have to do multiple roles. And poor decision support systems. This goes back to the information about data. Normally, we know that in a system like this, data is the bedrock that drives what everything has to run through. I'm sorry that in the image that I showed earlier, I did not highlight the LMIS. I think this diagram I had didn't have it. But the logistic management system or the information system for supply chain is the core of any successful supply chain program in a country. How can you know what to quantify if you don't know what you've used, if you don't have estimates of what you will use? And this is another pet peeve of mine, poor coordination of development partners and resources. When you're dealing with multilateral partners and programs that have international interests like HIV is one that I'm very well versed with. It becomes very difficult to manage the multitude of partners that run the projects. So for those of you who might not be familiar with the details of the HIV program, let me give you a brief overview of the kind of partners that are involved and at what level they are involved. HIV procurement, who gets to decide what HIV products are bought in Cameroon? We have the Global Fund. But not only the Global Fund, USAID also has special fund. USAID funds part of what HIV materials have to be purchased. The Cameroonian government has a stake in procuring HIV commodities because they are supposed to buy drugs to treat infectious, secondary infections for HIV patients. Those are just three, just in procurement. When it comes to implementation or management, right now there are about 4 main clinical partners in Cameroon. There's Georgetown University, whom I worked for, the Global Health Program. There is ICAP, there is the Baptist Health Services, and there is Elizabeth Glacier Foundation. And then when it comes to the regional level on who has to help get these products to the hospitals, we have new USAID-sponsored projects that are coming in to help deliver just HIV programs. We have chemonics, we have management sciences for health. And all of this have to work with the government partners. Don't get me started on when you go into the community. We have community partners, there's Care International, there's a million other people who are coming in now to work in the community aspect. And when you have to have all of these people collaborate on making decisions, it becomes very complex. And this leads to what we talk about, fragmented regulatory authority. You don't know who has direct authority. Is it the program head? Is it the malaria program? Is it the Department of Laboratory and Pharmaceutical Services? Is it the Senami? It gets confusing. And continuing with our challenges, they are endless. And I didn't even list all of the ones that I wanted to list here. I think another important program for individuals, some of us as healthcare workers, is that we never really think about the interdependency within the pharmaceutical system and the larger health system. The pharmaceutical system is usually seen like it's something of its own. It's a small scale thing that can run on its own, but it's an integral part of the larger healthcare system, and it's a system of its own. So it has to have some considerations on how it should be run. And funding. There's a lot of funding challenges for our public health programs. Those who work in the HIV space are aware of the changes that are undergoing, USAID is undergoing right now with funding for HIV. A lot of programs are beginning to pull out and things like that. They're discussing sustainability and things like that. And even non-communicable diseases are facing greater challenges. They don't even have funding for their public health initiatives. And then I already mentioned the logistics management systems. These are our information reporting systems. A lot of us are familiar with DHIS2. DHIS2 is a health reporting system. It's for disease management. It does not have a supply chain component. During COVID, a new system was developed called Open LMIS, which was supposed to be integrated into DHIS2. This is 4 years down the road. It never happened. So we have those silos. We have different systems managing different information. And at the end of the day, health workers, if you're a health worker working in one small clinic and you have to fill 5 tools because of your 5 rules, you will not do it. Inadequate tracking of pharmaceutical expenditure, poor procurement system and practices, and as well on the last mile, which is where the products get to the last person, there's inadequate infrastructure for storage, inventory management, and transportation. So I'm going to break down some of these problems in detail and show you some images of what I experienced on the field, and we can talk a bit more about some of them. I'm starting with the small scale problems, what you experience as a supply chain manager or as a health manager in a hospital. So these are real life pictures. I took them myself at the regional delegation of Public Health for Southwest. So this is my colleague, Mr. Bomba. He now works with Chemonics with USAID. And this was our regional store in 2020. There was barely space to move. It was a hazard waiting to happen. This is the parking lot of the regional delegation. There was no space for cars. These are all COVID-19 materials. Same thing here. This was us receiving the delivery of, I think these were protective gowns. And it was just very chaotic. That's all I can say. Poor storage infrastructure and just some of the small things. I think some of you have worse pictures where you come from. So these are COVID-19 tests being delivered on the floor in front of the delegation. You can see that some of the packages are even damaged before they arrived. So transport issues. You have walls of storage rooms cracking, leaking water into products that people have to use. And then vaccine storage. Sometimes there was not enough space to repack large quantities of campaign vaccines. And this is my favorite meme I like to put, where we expect supply chain managers to be miracle workers to find a way to make all of this work, but that can't happen. Lack of resources. Here I'm going to break it down to human resources, material resources. We already talk about financial resources. That's local level and national level. I wish Mr. Bomba was on this call. This is still my colleague, Mr. Bomba. I took these pictures from his LinkedIn. He at this point in this picture was a regional logistics officer, but he was the lone person responsible for delivering HIV commodities to all of Southwest for 2021 to 2022. That's when he started working with Chemonics, who had the grant to deliver HIV commodities. And he had to load them up on the trucks himself. Sometimes he had to even carry them on his head himself to the health facility. And the last picture is, this is an intern of mine. I think she was in Ameaka University at that time. And we had to, 3 of us, 3 girls, when I was working at the delegation, had to offload a truck, all of this truck of materials alone. There was no financing assigned for hiring extra staff for incidences like this. There was no extra human resources. I remember I ran the supply chain store of the delegation for almost 2 years on my own when my colleague, Mr. Bomba, left. And these are things that you imagine, a store like that managing all of the COVID-19 supplies for a whole region being managed by one person. You can imagine what can happen. So I love memes. I put this meme to illustrate. Welcome to the supply chain meeting. it's a team meeting, but you have one person sitting there because it's usually one person who has to do all the work. Please tell me my time. Tell me how much time I have left. So let me know what else I want to add and take out before we proceed. Brian, can you help me with that?
About 30 minutes.
Yeah,
okay.
Just about 30 minutes, yeah.
Okay, that'll be good enough. Thank you. So I wanted to use those pictures to illustrate some of the on-the-ground level challenges that we face. But now I'm going back to some higher level considerations because it's a multi-level system of challenges. The first one we'll have is what I like to call donor dumping, which brings me back to my initial question on how malaria medicines are chosen in a country. I think this question is even more relevant with sexual reproductive health, how contraceptives are chosen in a country. You'd be surprised to know that a lot of the time, the country has minimal say. The country would like to believe it has some say, but the country has minimal say in the kind of contraceptives that are chosen to be sent. For example, with contraceptives, UNFPA is the main donor for Cameroon with contraceptives. And I literally did a case study on this, which I was hoping to share if we have a bit of time, about the amount of wastage that goes into the amount of condoms that expire every year, condoms and lubricants that expire every year, especially female condoms. But these are products that keep being sent every year in, year out. So I consider it donor dumping when the donor does not consider the quantification needs, first of all, the product needs and the quantification needs of a country, and just goes ahead to send what its own estimates are for products. And with UNICEF, we experience the same kind of donor dumping. I hope there's no one who works for UNICEF here. I just have to be honest. With COVID-19, there was a lot of donor dumping for materials at the Regional Delegation of Health. I'm sure that if I go back there today, we still have some of those materials standing there. And poor financial allocations for supply chain in public health programs. I know when we say financing, every aspect of health itself is facing financial challenges, but I wanted to highlight this specifically for the fact that even for programs that do have funding, programs that have reasonable amounts of funding, like HIV programs that have been existing for years and are well-structured and have some semblance of order, when products are being sent to the country, the budget lines do not exist for how they get from the port to the last person. I've had cases where medications enter the country and have to stay at the port for months because there was no financing for clearing the medication. So you as a donor, it's a bilateral question. If you as a donor, if you're paying for products and you say you want them to get to the last person and they end up at the port, have you done your job? No. But if you say you're sharing this responsibility with the country and all the country had to do was to pay for the drugs to move from the port to the last person, that is still a cost that needs to be estimated. It's not a negligible cost. Sometimes, you bear with me, if you're a business person, sometimes the cost of shipping an item is even more expensive than the item itself. So it's worth considering. So here I just gave a very high level overview of some of the challenges that face supply chain management and the pharmaceutical system. And I talked about some of the more local challenges. Now I want to show you a few small scale solutions that have been tried. We know that you have to start from somewhere. This was in 2020 when we took over the regional storehouse. This was what it looked like before. And we went through a process of rearranging it to look like this. Obviously, this is not a perfect world. This is not how products should be arranged. But at least the second after picture doesn't pose a health hazard for anyone. We can navigate the store clearly. We can see where things are. Things don't have to get expired. We can follow normal warehousing procedures. And we had to lobby with partners like UNICEF to get like a dehumidifier to take out the moisture, lobby with the delegate to have some repairs done and things like that. Those are examples of little things that managers of pharmacies or small store rooms for medical procedures or medical materials can start. Sometimes these problems are called wicked problems for a reason. They are on so many levels. You have to start where you are. This is another example of an idea we tried. Instead of keeping the materials outside in the parking lot because we didn't have storage, we had to rent a church hall somewhere and put non-perishable materials or materials that will not be affected by some of these conditions like mosquito nets COVID-19 heavy equipment. And I think there are some storage bags here as well. And better coordination. I don't know if any of these guys are on this call. Pictured here, some of my senior colleagues, Dr. Banga Clarence, who was at that time working with WHO as a malaria consultant, and Dr. Faikal, who was working with Médecins Sans Frontières during the COVID-19 outbreak. And of course, the cartoons in the back. So we had weekly regional coordination meetings during the COVID-19 pandemic to try and structure our activities, to give complaints, to program things better, to avoid some of the challenges we're facing, and share materials. So that's an example of what better coordination could look like, especially within the HIV field. It's also been picked up a lot. While I worked in Yaoundé, there was a monthly regional coordination meeting for all stakeholders. And it was not just something to tick off the box. They actually had tasks and activities that they had to follow through on. And so I think just general communication and coordination with partners is needed. Now, I wanted to talk about systemic solutions. We've talked about what individuals can do and lobbying and things like that. But pharmaceutical systems are systems, which means they require systemic thinking approaches. If you fix one aspect, the other aspects will come back to play. We have seen that there are an interrelation of many factors. So some of the approaches that partners, international partners and local partners have been trying is what we call the continuous quality improvement approach. Some of you might be familiar with it or not. Just let me know in the comments if you are. And what we call a systems thinking approach, which is like thinking of problems from a large scale. I had a presentation to show you what a standard CQI improvement approach looks like. Not to explain in detail, just to give you a quick run through. But I don't know how much time I have. This was literally the last thing I had to do before concluding on this. So with your permission, I could end here or do a quick show just to make some of you familiar with what a CQI approach looks like. Brian, what do you say?
Yeah, sure. That's fine. You can just briefly just a quick overview of what the CQI approach looks like, and then we can.
Okay.
Yeah.
Okay. Since I wasn't sure I needed to present it, I have to stop the share and go there. But I will be very quick. It will be 5 minutes. So it should be right here waiting. It's a sample exercise that I did with a group, and it's based on work that I did while I was in Cameroon. So it's something that as public health professionals, we can think of incorporating, not just in supply chain. I think the CQI approach is something that is being used even in clinical care management and other practices. So this, I give credit to the team members who worked on this. This is not my presentation alone, but it was an example of quality assurance or CQI approach for condoms and lubricants at a regional store. I'm just going to quickly show you what is interesting for you to note here. Is that first you define the problem. If you're attacking the problem, first you define the problem, you find out the context and say what is the exact problem. Here, the exact problem is that greater than 10% of condoms and lubricants that were received in 2022 were less than 6 months to expiry, and they subsequently expired at the regional store. This was at the regional store of the center region where I worked. And so once you've defined the problem, you move on to understanding the structure of the problem. Here we use the same structure of the Cameroon pharmaceutical system, which I presented previously, but we adopted it to condoms and lubricants. Who are those in charge? UNFPA, USAID. We created all the structures, regional level, facility level, who is concerned. And then we moved on to a flowchart, which I will not explain. I just wanted to show you the tools that you can use in a CQI approach. First, a flowchart is to show what is the normal flow of activities that you're trying to look at. Because most of the time we try to attack problems, but we don't succeed because we are not attacking the right problem. We don't even know what the exact problem is. So a flowchart helps you to map out the whole process. Is it like during reception? How do you receive the products? How do you store them? And then identify where the problems are. And then next you can do a fishbone diagram, which breaks down different aspects of your regional facility, personnel, transport, warehousing, and then you start listing what you think the problems are. And this is what we did. For example, in personnel, we said staff were not well trained. There was not enough manpower, all of those things. And this was what led to an excess expiry of condoms and lubricants. Or there was not enough communication between UNFPA and the warehouse for material storage. And then lastly, you do a systems diagram, which is inputs, processes, and outputs. What goes in? You have the condoms. What are the processes? The condoms are stored. The outputs, they are poorly stored. So you have maybe expired condoms. But if you want to change the system, what are the new inputs you want to put in? Non-expired condoms, training, and then the outputs will be well-stored condoms. Once you do a systems diagram, you can do like a root cause analysis, which is you pick some of the most common problems and then you try to grade them on scores. For example, if you said communication between UNFPA and the store was the main problem, how can you solve this? Is it costly to solve? Is it feasible to solve? What's the impact of solving it? And the problem with the highest score or solution score, you can choose to attack first. So that's a way of prioritizing solutions. And this is the same thing that I did here. I just wanted to show you the last diagram, which would be performance indicators. Once you've decided on what problem you want to attack and you've seen that it's the most feasible, the least costly or whatever, you need to set some performance indicators. What are you going to use to measure that this changes that you're implementing will actually work? So these are some common supply chain indicators that we usually use. Shelf life, turnover rate. Turnover rate is usually how long does the product stay in the store or how soon does it get out of the store. And this is my last slide, which is what we call a PDSA diagram, which is a plan, do, study, act diagram. It literally just means once you've chosen the solution you want to attack from your problem, you plan, what do you want to do? What are the activities you have to actually do? Study, what are the things you need to check regularly? Act, after you've studied, what are the things you're going to do? And then you go back. So it's, these are core components of what we call continuous quality assessment. And usually needs a team of people in the same health facility to plan this together and then do it for a period of time and see if there's a change. So once you do it, you give yourself a timeline and you monitor over a certain period to see if you can find any improvements. With that, I will just go back and give my one slide conclusion, which is that if you fail to prepare, you're preparing to fail. So if you're working on a public health program and you fail to prepare and understand the different components that work within that system and forget to include the most essential one, which is the health supply chain aspect of a program, then you cannot succeed. And as always, I end with a meme. Supply chain should not be the last to know what the program plans to do. Thank you.
Well, that was excellent. Thank you so much, Dr. Fatima. That was a really great overview. I think many of us on the call and several others can certainly relate with some of the challenges that you highlighted. I think you provided a really broad supply chain management challenges that the Cameroon healthcare system faces. You outlined some of the critical issues from issues with coordination, data availability to inform some of those procurement decisions, infrastructural challenges, etc. So I think we're just going to give you maybe a few minutes to maybe take a drink of water, and then I'll try to engage the audience here a little bit. If you have questions, please, you can use the chat. You can raise your hand so we can have some discussions around some of the challenges that were raised, but also we would really like to hear your thoughts on potential solutions. We are hoping that we can coalesce or put together some sustainable solutions that could help the public health programs in Cameroon as well. I would like to maybe invite a few people. I do see that the Dr. Josh Nkome is on the call as well. I know you've been the technical advisor for the Cameroon Baptist, the CBC in Cameroon. So I really love to hear your thoughts as well from Dr. Fatima's presentation, what your presentation has been, what your experience has been in the field working in supply chain management for this many years. Dr. Kome.
Thank you very much, Brian. Hello to all. I would like to apologize for network reasons. I connected late. I hope I'm audible enough.
Yes, we can hear you.
Thank you very much, sir. I think it's a very interesting presentation, even though I unfortunately came to the end. But in my small capacity as technical advisor for supply chain in the HIV-free project, there are some points that she brought up that reminded me of some of the challenges we have been having. And one of the first things, in my opinion, is the fact that there is a disconnect between supply chain management and clinical activities, such that sometimes those who handle commodities, they give the impression that the clinical team is not really concerned. Let me just give you a practical example. I compile reports and submit to CDC on a monthly basis. And you can imagine me having a report from a site showing that they have a certain ARV, 2,000 boxes. And then that same day, while I'm working on the report, the site lead, the physician in the treatment center, calls me and tells me that the previous week, they had to ration that particular commodity and give 20 tablets. And I was telling him that I'm in front of the Excel sheet and seeing that they have 2,000 boxes. And this is only because when the people provide the commodity report, there is not that collaboration with the clinical team. Secondly, the issue of not doing quantification based on some clinical pictures. So those are some of the reasons at the facility level. Now, at the upper level, I think sometimes people do estimations because I attended some quantification meetings. I noticed that people do estimations not based on sometimes the realities on the field, but based on maybe what they think, well, if the government can provide this quantity, let's just manage that. Because sometimes you see where they estimate that maybe we have 9,000 exposed infants, and then they're planning to have 8,000 EID reagents. So you ask yourself, if we have 9,000 exposed infants and we have 8,500 reagents, it means that some of these infants whose final outcome will not be known, and some of these children may be infected and never diagnosed. So I think I just wanted to appreciate, when I saw the topic, I really appreciate, unfortunately I connected it. But supply chain management, I think, is very important, and it's time we start having that blending within the daily clinical activities. I'll end there for now. Thank you, Brian.
Yeah, thanks a lot, Dr. Kome, and really thanks for sharing your insight. It's really great to hear from people who have really had real-time experience with supply chain challenges in the field, and really congrats also for your long-standing work with the procurement of HIV medications for the regions as well. I also want to invite Dr. Samuel and Jenica. We really love to really hear your experience as well. I know you have lots of practical on the ground experience in Cameroon. You understand the realities of this issue. Really would love to hear your insight from Dr. Fatima's presentations and what your key takeaways were. Dr. Samuel.
Thank you very much, Brian. And I want to again thank Dr. Fatima for the excellent presentation. As I was planning and getting ready, I really wanted to hear more, which she explained very eloquently. How do we actually get the product to the user and to the community? That was more in my mind. And when I hear her say no product, no program, that was really on it. And the diagram, the flow that she had, we have that challenges of actually how we have Sename in the middle. The challenges is for the hospital. You take for our hospital, like Grace Garden Hospital in Dub, having access to the product, as Dr. Fatima has explained, was really on it, because there are many organizations. When you look on this diagram here, especially when you get from the donors, the word donors dumping, because she asked a question which at the end, we are still on it. How do we decide a product? Take, for example, malaria. How do we decide? Is it just because it's available from the donors that they will just give us? I've been working with Dr. Mark Sandrine, and there might be many other people on here. There are few pharmacies in Yaoundé that actually have, for example, hydroxyurea. She worked with a group from India and pharmacy in France, working through Sename to just get hydroxyurea to Cameroon. Yes, we have chemonics. I think this is something that we're really looking to see, as she's talking about having an agency that is available to actually run supply chain. The challenges we've had, she laid it very well, outlined them very well in this presentation, which is very, very helpful, especially if hospitals, regional hospitals, actually the storage of those medications when they get to where they're supposed to go. If we have challenges at the region, how more of the different institutions. So I think this presentation was very, very important for us and was right to the point. I want to appreciate her again, and thank you, Brian, for giving me the opportunity.
Yeah, thanks a lot, Dr. Samuel, and also thanks for really all the excellent work that you're doing in Cameroon as well. Much appreciated. I also want to recognize the presence of Professor Shea Wisonge. I know he joined us. I don't know if Prof is still on the call. Would love to hear from you as well. Yeah, if Prof is not here, would love to hear from Dr. Theodore Ngachu. Okay. So if anyone has any contribution, I think you can use the you can raise your hand in the Zoom chat. I think a lot of people raised some very pertinent discussion points during the presentation, which I thought were most appropriate for the Q&A and also for the discussion. So I'm hopeful that we can have some engaging conversations around some of these issues and potentially come up with solutions that would be very helpful for our context in Cameroon. So if you have any questions, please feel free to either use the Q&A section, or you can raise your hand, and then myself or Dr. Mona will try to call on you. So I'll start with Dr. Patrick Mbomba, whose hand is up, and this is the person that I think Fatima referenced during her presentation. So it's great to have you, Mr. Mbomba. Please, you have the floor.
Thank you very much, Dr. Fatima. Merci beaucoup pour la présentation. I will speak in English. So I nearly cried that Dr. Fatima posted me some of the pictures, which is really good because we did a lot of things together. I'm always happy when I hear Dr. Fatima contributing about our supply chain system in Cameroon. She mentioned something I'm really, really happy also. Not all our pharmacists are logisticians. And we also know that logistics is another field, which is not something that pharmacy dwell on a daily basis. So it's something that we really need to take in consideration. I'm a logistician, and with the support of our colleague pharmacy, we're able to do many things together. So thank you, Dr. Fatima. I was expecting her to say something about the last mile delivery, that me as a regional logistics officer and also like storage and distribution advisor, I was handling both at regional and national level. So maybe she will say something about that. And also another point that I miss, human resource, which is also one of the challenges that we also have here in country. You may have, especially those movements within district or within region that some people are trained after they are moved to another region, vice versa. And so we really need to emphasize about the workforce. So I will be loved that she will say something about that. If that one also, because I feel there's also some challenge that we are really facing here in country. We have a lot of rules, a lot of mechanisms, but at the end of the day, when people are not trained, when the people are move up and down, we still have challenge. Thank you very much, Dr. Fatima. Over.
Yeah, thanks a lot. Before I transition to Dr. Fatima to address some of the points that Patrick Bomba raised, I really wanted to also again recognize the Dr. Joseph Fokam, who was appointed as a permanent secretary for the National AIDS Control Committee. It's really great to have you, Dr. Fokam, and would love to hear your thoughts as well around the challenges that you've seen in the field and some potential solutions that you envision would be helpful and sustainable for the public health programs in Cameroon. Dr. Foka.
Yes, thank you, Brian, for giving me this opportunity. So when I saw this topic, I quickly switched off other agenda because it's something that's quite concerning at my level, actually. As a matter of fact, I'm on board for like just 3 months, but on a daily basis, this is my major challenges. My major challenge, in fact, procurement and supply management is really a big issue. And you must be aware of the current query between the Cameroon government and Global Fund with respect to some of the deep freezers that were supplied. There are like 239 deep freezers supplied by Global Fund with their UN partner, UNOPS. So in some of those situations, the government seems to be blamed, but the donor himself at the same time is playing the role of the supplier, and it makes things quite complex, quite very complex. So, but I really want us to discuss the simple daily routine issue with respect to supply chain management. And since I'm on board, I realize taking the example of the AIDS program, generally we really do supply, we do our supply and management system beginning with product selection. And this product selection, really, I'm happy with what Fatima showed. This product selection in most of the cases are determined by the funder. This is true. Global Fund will tell you this is what is available, and in most of the cases, it's either you take it or you buy whatever you want, counterpart funding. So it's quite challenging. So from my experience, what I realized makes it difficult from our end is because we don't communicate enough in terms of scientific evidence. And because we lack evidence, they will dictate whatever they feel is the best for us. Yep. So one of my main encouragement actually is to see how, based on our local experience in supply chain management, we should be able to do a good documentation, then communicate those experience through scientific publications, attend meetings where we can discuss with those partners. Then that's the most efficient way I see we can easily bring our opinion on. Otherwise, you keep on being really a difficult issue. Just for now, like for HIV, we had a serious battle with Global Fund. Why? Because we did a verification study to select HIV rapid tests in the country. The Global Fund, they had their own vision, but it is only because we had really strong evidence that they were that they had to accept our proposals. So without evidence, it will always be very difficult. And that's why it is true I'm more science inclined, but I really hope our pharmacists, our should be able to publish our local experience, our local challenges. That's the only way we may be able to convince them. So for HIV now, we'll be getting new procurement based on our own local evidence. But again, for malaria, even just for malaria rapid tests, getting malaria rapid diagnosis test, the permanent secretary will tell you the funder is the one proposing what you take, because you have no strong evidence to maybe to give a counter indication. So my main struggle will be to see how we can really work together and document, then communicate what we have as experience. Then my last question also for Fatima is something that I really enjoy in her communication. She talked about the collaboration between logistician and pharmacists. Actually, I have weekly working sessions with my collaborators, and I realize at times pharmacists feel they can also be very good logisticians. That's how sometimes they give. So at times the logistician will give his opinion and they will tell him you are not a pharmacist. So Fatima, what's your advice in terms of improving the collaboration between logisticians and pharmacists so we can really improve our procurement mechanism? Thank you.
Brian,
Yeah.
do I have the floor?
Yeah, I think Dr. Fokam raised some really critical points during his communication, and he talked about some of the challenges around product selection for HIV for programs like the HIV/AIDS program. He mentioned the engagement of different stakeholders. He talked about Global Fund. So without the procurement of this of medications from these donors without sufficient considerations of what the local needs are and the evidence. So one of the points he really talked about was the mismatch between what is actually procured and what the actual requirements on the ground are. So I think as this is one of the points that has been constantly re-echoed throughout has been this disconnect that exists between what the local needs are and an accurate assessment of what the local needs are and what should be driven. So I just want to transition to really give it to you to maybe to hear your thoughts based on Dr. Fokam's discussions on some of these systemic issues that I think he raised, what your thoughts are on how Cameroon might be, how we might be more better suited to address this moving forward. Dr. Fatima.
Okay, thank you. I've actually been enjoying listening to this. I will start with Dr. Fokam's remarks and I'll go back to Mr. Bomba's questions. He did say something which I found very interesting. It's about using evidence to make arguments. It seems like an obvious thing, but it's also been very lacking in some of the public health decisions that we have made in Cameroon. I know that when it comes to making decisions like this, especially with donors and multilateral programs, evidence is not the only thing, but it should be the first thing. Because a country like Cameroon cannot monetarily stand in comparison to the Global Fund. We have this dependency. I could address that later because my focus was on policy in my MPH, so I've been focused a lot on power displays. But what I loved about it was the good example he talked about using the HIV rapid diagnostic test. I think my former colleague as well, Julian Frank, is here. He will talk about the challenges we had on the field with using HIV tests that were not appropriate, were not giving results, but they do not kept saying that you had to use them. But I'm glad they finally won that battle with using evidence to prove that this is not appropriate for us and it's not working. So hopefully other programs can use that kind of logic and arguments, and we as researchers in our own data spheres can use that to make more solid arguments. So that was a good solution he proposed. And another solution I could bring up when it comes to these donor partnerships and the fact that a lot of the donors force us to do things that we would otherwise not want is that we need to find power. We need to find more negotiating power as countries of the global south. A lot of countries, especially in Southern Africa, are beginning to have more tight regional ties and not just economic ties, like within the health space. If you decide you want to partner with, say, Cote d'Ivoire, with, say, Togo for a specific health case, say, okay, maybe we want to do bulk buying for our HIV commodities. We want to negotiate with the Global Fund or with a producer as a group, as a region. It begins to have a different conversation than when you're an individual. So that's one thing we could also explore for where it's feasible to find regional partners to make negotiations with, and to also realize that with donors, we might not have the monetary power, but there are other things that we could bring to the table to put pressure on them, because they give the money, but they also need the results. So if they don't have the results, then it won't work. So we have to demonstrate that what we're asking for, we give them the results that they want. The other question he asked about improving collaboration. It ties into what Mr. Bomba said, so I'll kind of link it up about human resources for supply chain management. Pharmacists are not logisticians, but Cameroon, at the point that we're speaking, Mr. Bomba and a few other of his colleagues are the few logisticians that are currently existing, and not just logisticians. Health logistics is different from different kinds of logistics. You cannot work for maybe a mining company, you work for Bolloré or something, and then you think that makes you an expert in health commodities. They are two different things. Someone like Mr. Bomba worked for the regional fund for over 20 years. So that's a different kind of experience that we want to have. And so I think that improving collaboration is realizing that we bring different parts of expertise to the table. The pharmacists have the medical knowledge and the importance of preserving the product in the right way, and the public health knowledge, which is vital for understanding what works. And the logisticians bring in the more technical knowledge. How do we get this product from A to Z? How do we store it properly? All of those type of things. So I think a better way of collaborating is to understand the strengths that each person brings, and also for the logistics aspects of health logistics in Cameroon to be more developed. I think there are organizations trying to build that up. There's an international organization called People That Deliver. They have been pushing for more training of local logisticians, medical logisticians who can support public health programs. So that answers both the human resources issue and others, because there's a serious lack of human resources. I already cited the challenges we went through while we were working on the field. And in smaller health centers, it's even worse. I wanted to talk about last mile delivery, because this is also a very important aspect that I think in the course of my presentation, I didn't highlight as key. It is one of the biggest challenges with supply chain and health programs currently in Cameroon. The HIV program went around this by bringing in chemonics. USAID brought in chemonics and paid chemonics to do last mile delivery of HIV commodities for the whole 10 regions of Cameroon. But this solved one problem and left another. You cannot go to a health facility on a Monday, you deliver one carton of antivirals, while they are still waiting for their malaria supplies that were at the very delegation that you left to come just with the HIV carton. Julian will even speak about this. We had situations where when we do quantification for monthly supplies, you will have a health center who has just a box of medication that they need. You cannot leave their condoms in cartons and carry just that box of medication and go give them. So when USAID paid chemonics to supply for HIV, what about the other public health programs? So we have to start thinking. I'm glad that the new Dr. Joseph Fokan is here. We have to start thinking about collaboration across vertical programs, because it's crippling us when it comes to financing. You cannot be in the same source using the same resources, and then you're having supplies for one program to the detriment of other programs. It's a collaborative something that we have to work on. And then the fact that health facilities have no, in fact, let me not even go down to health facilities. Regional delegations and regional funds are suffering from a great underfunding for public health programs. The regional funds were usually responsible for directly supplying health facilities with medication, both essential medicines and public health programs. But as we stand, especially in regions like the Southwest, even the center region, we still have health facilities having to travel from Monatele or wherever to Yaoundé to carry their products. And this money usually comes out of the pocket of the health facility, which is unheard of, which is not something we should be talking about. So last mile delivery is a huge challenge. I have to applaud the work Chemonics has been doing, though. It's been an amazing thing that they have done, and they have found very innovative ways of getting products to even the smallest health facility, wherever. But we have to think about it not just in terms of HIV, but what about the other programs? What about essential medicines? Why are the regional funds being underfunded and lacking vehicles to deliver even just basic commodities? With that, I will let the other questions come. And then
thanks a lot, Fatima. I think I'll take Crespo and then move on to Julien Frangomba. Crespo, please.
Hi, Fatima. Thanks, Brian. Excellent presentation. I just have lots of worries around this because like maybe 5 or 6 years ago, we had tried to bring in some medications at the time. I was trying to collaborate with Dr. Sangawa, the anesthetic, and these were cancer medications, and it was just really, really bad. So my questions would be, is there any logistic management information system that is in the country? And if it's yes, is it like regional or central? Who controls it? Because I feel like if we have a system like this one, we can be able to know what we're supposed to do at a given time, and we can be able to of course, know that, okay, so today this is not going to happen because we have a breakdown in the system here. So I want to know if we kind of have that kind of system. And the next one, it will be in terms of quantification and the supply planning. Is there any, like, regionally, are there any system that have been in place for like quantification and planning of necessary supplies for like the essential meds you're talking about, Dr. Fatima? And then my last one is on slides, I think 16 or 15 of your presentation, where you had the flow chart. You talked of the different donors and the different people who can give medication. I'm worried that sometimes, since you talk of dumping, who does any quality assurance or quality control on these products? Like, once it just reach, it's we just take it and then we just use it. Given that in other places it wouldn't happen like that, no one is even gonna look at it. So those are my three comments that I had in terms of this whole procedure.
I would like to maybe answer that, because I think Julian will have answers more than questions. I know him. So those are really good questions. For the LMIS, I did touch on this. I did mention that the logistic management systems, when it comes to medications and commodities in the country, is quite fragmented. We know that the health data in Cameroon is collected through the GHIS too, which does not have provisions for collecting information like this. The other public health programs have been having individual systems. For example, HIV used DAMA, which was created by the Baptist Health System and kind of spread out to the other programs. They use DAMA, and they have also a few internal systems, but most facilities use DAMA. And there was a new one that was being introduced. I quite forget. I think someone else in the chat might remind me of the new electronic health system for HIV that was being introduced. And they were hoping to use that for other programs as well. During COVID, there was the Open LMIS, which also had sexual reproductive health data, but it didn't quite take off as it ought to. It was mostly filled at the regional level. Facilities found it difficult to fill, and at the end of the day, a lot of them abandoned filling that information. So that brings us back to what you were asking about. When we have to do quantification, it gets very difficult, because if you have to gather information from all these fragmented systems to make sense of one whole picture, it poses a challenge. That has been the main challenge. And you talked about regionally, are there existing quantification mechanisms? There is, especially for HIV. We called it a regional coordination team, which was composed of both the government counterparts, the supporting partners, the HIV partners, the clinical partners were involved in every month, including chemonics and the distribution partners, every month planning supplies. So this was a bit better, because the clinic, at that time I was working on the clinical side, not on the government side. And I'd been able to develop individual systems for collecting this information, which we shared with the government. So it created an avenue for sharing information. Then we made decisions together. Okay, these are the sites, both PEPFAR supported sites and non-PEPFAR supported sites. We're going to do the distribution and quantification together. That worked for HIV, but as I said, it also leaves the gaps in other programs like malaria and TB, which fell a bit to the side. By the time I left last year, there was a talk of trying to bring all three to the table, which is why I was talking about collaboration. And lastly, a very pertinent question about donors and what happens to donor programs and what are the proper channels. So when it is donors within public health programs, it is slightly more organized, but to be truthful with you, not as quality assured as we would like. For example, if UNFPA donates condoms to the reproductive health program, it's already standard practice. I did internships at Lanacom, which is the natural testing laboratory. And I'll be honest that I can count the number of times I saw condoms for UNFPA being tested. Probably not. But in this case, you can say there's a history of trust, and there's probably quality control certificates that come with public health programs like that. But we've also had issues where we've had supplies that look substandard from recognized partners. I will not mention names. But it gets more complicated when you have individual donors, like you, if you were explaining the case where you're working with another international partner and you want to bring in medication, or even you're a partner like Médecins Sans Frontières, who is not a recognized partner for a general maybe health program, and you want to donate maybe essential medicines. There is a branch of the Department of Pharmacy and Drugs, known in French as DPML, that is in charge of that. Usually you need to get an authorization from them, and they're responsible for the quality testing and stuff like that. But also, it takes a long time, and if you don't start the process early enough, your product might not get there when when you need, but it's possible. It's possible. I did go to an inspection for Medecins Sans Frontières once when I was working at the delegation. So it's something that can be done. You just need to engage the right process. But a lot of health campaigns from international programs don't know these mechanisms. So they have their programs stalled because they can't use those programs. Or they come dump it without the proper authorization, and then the products can be used when they leave. So
yeah, and thanks, Crespo, for really bringing up that. I remember when the minister was here, when he came to speak to us, he outlined some of the national digital health strategic plan, and discussed some of the new tools that were being harnessed in order to increase surveillance for different things. So, Dr. Just wondering if there are ways that the DHI2 system could be integrated with LIMS, what the Crespo brought about. Are there ways that both systems could be integrated to really improve surveillance for both epidemiological surveillance and also for procurement of drugs, and really having more robust surveillance mechanisms across the national territory?
I'll let Julian add to that, but I'll just say this. The DHIS is not a Cameroonian developed tool. It's an international standardized tool. And if you want to, if Cameroon wants to create certain specificities for its need, they have a process to go through. And it was a tool that was not designed for that. Doesn't mean that it cannot be manipulated to give that, but also Cameroon will need to go through that process. I don't know at this point in time if someone has engaged that, but I'll let my colleague, who is maybe more current than I am, to answer that while he asks his question or make his remarks. So maybe when Julian speaks, he can give us some info.
Sure, definitely give that. I do note that Dr. Fokan did mention in the chat that Vindata, and Vindata is another tool, which is, I think that was mentioned by the minister, if I'm not mistaken. So thanks a lot for that. I'll just move on to Julian. Julian, your remarks, and then afterwards we'll have Jude. Julian.
Ok. Mais déjà, Fatima, pour cette initiative, je vais devoir parler en français parce que, bon, pour un domaine aussi pointilleux, je ne suis pas sûr d'avoir les mots en anglais pour m'exprimer correctement. J'espère que tout le monde pourra me comprendre. Déjà, par rapport à ce que tout le monde a dit jusque-là, vraiment, je suis totalement d'accord et je vais plus essayer d'aller dans un niveau.
Votre réseau est un peu instable.
Pour la chaîne d'approvisionnement au Cameroun. Allô?
Oui, votre réseau est un peu instable, mais vous pouvez continuer.
Ok. Bon, je disais qu'il y a, que ce soit le programme VIH, la TB, le paludisme, la SR, il y a un gros problème au niveau de l'utilisation. On peut faire la meilleure planification au niveau central, faire la meilleure distribution pour le LMG. Mais quand ça arrive au niveau de la formation sanitaire, si les formations sanitaires ne sont pas dans un usage rationnel du médicament, je peux vous assurer que vous allez acheter 100 médicaments, il y a 40% qui ne seront pas utilisés et qui vont au final aller à la poubelle et qui vont perturber l'approvisionnement de ceux qui en ont réellement besoin. Donc, il y a un gros problème à mon niveau en termes de formation pour ceux qui sont, par exemple, supposés suivre ces formations sanitaires-là et s'assurer de l'usage rationnel. On va prendre l'exemple des points focaux GAS de région et un moment de district. C'est très récemment, il y a quelques années que, disons, ce poste a été vraiment, on va dire quoi, confirmé sur le plan officiel et il y a des formations qui ont commencé à être faites dessus, mais il y a encore de gros manquements parce que parfois vous trouvez un point focal GAS de district ou même un point focal GAS de région qui ne sait pas exactement ce qu'il est censé faire. Il ne sait pas quelle est la méthode qu'il est censé utiliser pour faire le travail qu'il est censé faire. Du coup, les partenaires, par exemple, peuvent être en appui, mais on ne se retrouve pas au final dans ce qu'on appelle le renforcement du système. On est dans quelque chose d'un peu plus, on va dire comment, un peu plus fugace, c'est-à-dire que ça ne va pas mettre long. Dès que le partenaire change ou dès que le partenaire s'en va, le système s'écroule à nouveau. Et je crois qu'il serait bien qu'on commence à penser véritablement à ce qu'on appelle la chaîne d'approvisionnement. Parce qu'il y a de gros vides sur le plan normatif en termes de chaîne d'approvisionnement au Cameroun. Que ce soit le pharmacien, que ce soit le logisticien. Moi, je vous dis, il y a des pharmaciens qui sont de très bons logisticiens dès qu'ils se rendent compte que leur argent est en jeu. On a tous fait des officines. Je vous dis, là-bas, ils gèrent des références, 3000 références, 2000 références en moyenne dans une officine, et il n'y a pas de manque là-bas, tout se passe très bien. Mais quand on arrive dans le système public, on se retrouve que subitement, personne ne sait plus rien. Donc, premièrement, il y a un souci de formation. Deuxièmement, il y a un souci de qui est comptable de quoi. Quelqu'un est censé être responsable d'un stock d'intrants dans une formation sanitaire, mais tout le monde, étant donné que c'est un intrant qui est payé par le bailleur de fonds, la formation sanitaire n'a pas déboursé un agent pour payer. Tout le monde s'en fout, personne ne veut gérer le produit. Vous envoyez des intrants dans une formation sanitaire, vous vous retrouvez 3 mois plus tard que 90% a périmé sans que personne ne lève le petit doigt pour éviter ça, alors que la formation sanitaire d'à côté est en déficit de ce même produit. Et entre autres, ça rejoint le problème justement de l'information, parce qu'à un moment, remplir même les outils, les gens ne veulent pas. Tout ça, c'est une question de qui est comptable de quoi. Et tant qu'on n'est pas dans un système où les gens doivent répondre de leurs actes, je vous assure que ce sera très difficile de venir à bout, parce qu'au niveau central, quand vous regardez véritablement les efforts qui ont déjà été faits, on a beaucoup progressé en termes d'approvisionnement global au niveau du pays. Il y a eu beaucoup de progression, il y a eu beaucoup de choses qui ont déjà été faites. Maintenant, je vous dis le plus gros challenge, et je parle de par ce que je fais au quotidien. Suivre les formations sanitaires, c'est un vrai challenge. Tout le monde fait ce qu'il veut. Les médicaments peuvent périmer, personne ne va rien lui faire. Et c'est très difficile d'évoluer dans un système tel que celui-là. Et je crois que j'ai cru entendre Dr Fokam parler justement des évidences, peut-être pour mieux organiser les choses. C'est vrai, mais je pense que c'est un peu normal parce que c'est un domaine qui jusque-là, chez nous, n'était pas mis en avant ou alors on n'avait pas cette façon de faire là. Je pense qu'il est tout à fait possible de stimuler la recherche scientifique. Il y a de plus en plus, par exemple, de pharmaciens qui sont dans la santé publique, santé globale, etc. et autres là. Si il y a, par exemple, une volonté de la part d'une CNRS, je ne connais pas toutes les méthodes pour procéder dans ce sens, mais je pense que s'il y a des moyens quand même de stimuler la recherche, on pourrait se retrouver facile au bout de quelques années qu'on a vraiment toutes les zones d'ombre pour lesquelles on avait besoin d'éléments concrets en termes de recherche qui prouvent que c'est mieux de faire ci plutôt que de faire ça. On pourrait l'avoir en un claquement de doigts. Il faut juste qu'on s'asseye et qu'on réfléchisse au problème. Le niveau central, les approvisionnements, vraiment, les gens font déjà du très bon travail. Ce n'est pas ça la plus grosse difficulté qu'on a actuellement au pays. C'est l'usage dans les formations sanitaires. Et vous allez vous rendre compte que personne ne s'en occupe. Tout le monde ne regarde pas ça. C'est le jour qu'il y a problème qu'on vient demander que pourquoi il y a problème. Mais il y a problème parce que personne ne s'en occupe. Et à chaque fois, quand il faut résoudre le problème, on résout le problème de façon ponctuelle et on ne cherche pas à mettre des mesures en place pour que ce problème n'arrive plus à l'avenir. Et ça demande vraiment aussi bien des compétences en termes de logistique, des compétences en termes de clinique, des compétences en termes de management. Vous avez un point focal gaz, par exemple, qui ne comprend pas, qui ne sait pas ce que c'est que la supervision, comment on fait la... Et même en termes de gestion de données, s'il ne comprend pas la donnée, comment il va savoir, il ne peut pas, il trouve même que ce n'est pas important que la formation sanitaire lui envoie l'information ou pas, puisqu'il ne comprend pas de quoi il s'agit. Donc, c'est vraiment le challenge, la formation. Qui est responsable de quoi? Qui doit répondre de quoi? À chacun à son poste au niveau des formations sanitaires, de l'usage des produits qui sont payés par les bailleurs de fonds. Et également, il faudrait juste qu'on se concerte pour stimuler la recherche scientifique sur le sujet. Et je suis vraiment convaincu qu'au bout de quelques années, on pourrait avoir tous les éléments dont on a besoin. Après, on fait donc, on s'assoit pour avoir des textes sur le plan normatif et autres là, pour que tout soit bien clarifie, tout soit bien clair. Question que, avec par exemple le problème de rotation des personnels dans les formations sanitaires, si tout est bien mentionné dans un document, comme par exemple au niveau de la DPML, il y a le manuel de gestion des intrants, mais ça c'est vraiment le b.a.-ba de la gestion. Mais il faut aller au niveau au-dessus de ça. La supervision, ça se fait comment? Qui sait comment? Quel est le canevas? On a par exemple pris dans les directives nationales, par exemple, quand vous regardez la partie gestion des intrants, elle est très courte, c'est une petite partie, parfois c'est un paragraphe. On a fait un manuel de la gestion d'un programme qui fait 200 pages. Vous regardez la partie gestion des intrants, c'est une demi-page. On va s'en sortir comment? Donc, il faudrait qu'on soit un peu plus assidu sur les aspects normatifs des programmes, par exemple, en particulier. Et vous verrez que le médicament essentiel dans la formation sanitaire n'a pas de problème. Parce que les gens ont leur qui est engagé là-dedans. Donc, voilà ce que je pouvais dire. Merci.
Non, merci beaucoup, Julien. I really appreciate all the points that you've raised. Have you seen other, I did some countries in Africa that you've seen that mirror really some of what you think Cameroon could leverage or learn from some other countries in Africa? Similar, resource allocations and things like that. Have you seen good systemic or surveillance mechanisms in other African countries that you think that we can mirror, with the exceptions of countries like South Africa?
I could jump on that. Julien will share this with me. Last year, when Cameroon was trying to start this new HIV initiative of having pharmacists deliver antiretrovirals, they were copying I've forgotten what partner was in charge. It should be PSI or Family Planning 360. They were copying work that has been done with Kenya. Yeah, it was Kenya and Sierra Leone, but mostly Kenya. And the main challenge that Cameroon had with trying to implement such a program was they wanted to use DAMA, which was the existing system at that time, where the hospital could see the same records as the pharmacy. And the hospital will send the patient's record to the pharmacy to be able to say, okay, this is the patient receiving treatment at my HIV treatment center. You can give them, if that's stable, you can give them medication at the pharmacy. But so Kenya has a pretty good system where as an HIV patient, you can go to any hospital and they will have your information. While for Cameroon, it's kind of limited. For example, Cameroon curbed this problem by pairing pharmacies with hospitals, which meant you could only go to this pharmacy linked to your hospital because that was the only pharmacy that could see your data through the DAMA system. While in a country like Kenya, based on level of access or the patient code, the data system is a bit more widely open and it's a bit more advanced. But honestly, nobody is there yet. And Julien pointed out that it's a new field, so we have to start thinking about setting standards because that's the main thing. People don't know what they should be doing and why they should be doing it. And he said, even with the progress we have made nationally in our ability to procure medication, when it comes back, even after the last mile delivery, I know this talk was to end on last mile delivery, but as a pharmacist, after last mile delivery, we have dispensation. And if that is not done, that is a problem. And that's what he was pointing out, that sometimes the medication, even after all the struggles, we get it to the facility and that's where it gets expired because it's not properly used. And that's also an important challenge that we need to address. So we have to start by setting the norms, who is doing what and why. And those are things that don't exist then. We always say Cameroon has good documents which they don't follow. But in this case, they are not even the documents existing. So there's a huge gap. And I love calls like this because we have people from diverse backgrounds who can use their little influence wherever they are to make some of these steps go forward.
Right. Yeah, thank you so much. I would take two last questions from, I see Jude's hand is up and also Frank Nwamo, and then we'll take the final question from the chair, Dr. Mona. Jude, over to you. Jude, if you're speaking, we can't hear you. I think we may have lost Jude, so I'll take Frank and then afterwards Dr. Mona. Frank, you're muted if you're speaking.
Ok, je vous remercie. Pardon encore, je vais prendre la parole en français parce que justement mon niveau en anglais n'est pas, c'est un des meilleurs. Bon, en fait, je voulais revenir sur l'intervention de Julien Franck. Et bon, pour être franc avec vous, je n'ai jamais travaillé au Cameroun, je ne connais pas la réalité, je suis un médecin de la diaspora. Et j'ai cette ferme conviction que le game change vraiment dans le système de santé, que ce soit les problèmes de logistique dont vous avez parlé, tout, là, je crois que la clé, ça va être de l'entrepreneuriat parce que je crois que quand, en quelque sorte, il y a des personnes qui viennent pour régler des problèmes pratiques, je crois que ça va changer la donne. Bon, c'est clair qu'il y aura toujours des problèmes de financement et comment est-ce que, mais je crois en fait que c'est ça. Et je ne sais pas si de tout ce dont vous avez parlé, tous ces problèmes de logistique, comment on dit, de réduire, comment on dit, les médicaments, peut-être qu'ils sont de database informatique, ne sont pas très bien intégrés, information de formation. Est-ce que selon vous, bon, sais pas qui va peut-être me répondre, une solution concrète qui va devoir créer un modèle économique et après, tout va. Mais je crois en fait que ça, c'est la clé. Parce que c'est vrai, on est pauvre, les États sont ce qu'ils sont, il n'y a pas. Nous, comment dire, des personnes qui nous donnent des choses gratuitement, mais toujours dans la gestion, c'est pas, on n'arrive pas à gérer tout de manière aussi efficiente pour vraiment profiter de ça. En fait, je suis encore dans une phase d'exploration, mais avec une vraiment conviction très forte. Si vraiment tous ces problèmes-là, comment on dit, ce sont des opportunités vraiment pour chercher des investisseurs, pour vraiment apporter des solutions réelles, quoi. Je vous remercie.
Okay, Fatima, I don't know if you had any answers, but I see Jude is unmuted. Jude.
Sorry, I'm connected with my phone, so I had to change my phone. The other was giving me trouble. So thank you, Fatima, for the presentation. And I see that the supply chain management in healthcare, it's a very important topic for us because like every other chain system, without adequate medications reaching the clinicians, they are not able to take care of the patients that visit their clinics on a regular basis. And it's quite unfortunate that in our system in Cameroon and many other communities, this system still kind of decolonized or still kind of under a colonial trend. And because that's what we call it, because if you see that most common infections that are plaguing the community, like malaria, HIV, and all the like, still have to depend on donors for important or essential medications to meet the daily needs of their people suffering from this, then it's really a call for concern, which I think all of us are aware of that. So my question is, you as a specialist in this field, if you happen to be appointed, let's say, a minister today, like what 3 important strategies will you put in place to decolonize this system and make it sustainable, and that we reduce this disparity? Because when any colonized system, there will be a lot of disparities in the reach or in how the people are able to benefit from whatever medications are being supplied to them. So my question is, how will you, or what strategies will you put in place, 3 important strategies that you can put in place or recommend to see that we decolonize this kind of system in our country? So that's just my question. Thank you.
Yeah, Fatima, you can go ahead, please.
So Jude is trying to make me minister. Okay. That's an interesting question. And I think the last couple of months, we've been leading, I'm part of an organization called the African Public Health Network, and we've been leading a lot of conversations around decolonizing global health. I think a lot of you have heard about this statement and the topic and what it entails. I think in one of our last talks, someone said it's something of a lofty ideal if you don't break it down to simple terms. So let me not say what I want to happen. Let me say what can actually happen and what is practical enough to happen. 3 structures to put in place to decolonize the system. I think the first one, which can apply in any system really, stop trying to compete at an international level. Our competition is with our neighbor. So basically, if the standards we keep trying to meet are international standards, we will keep failing. And then we'll keep feeling like we're the beggars and we have to meet up. But if we leverage our regional networks, that's where we win, because our neighbors look like us. Our neighbors share the same history as us. We're the same tribes. We're literally just cut off by colonial boundaries. And we have the same interests and the same challenges in our healthcare. So South-South collaboration, learning from the people around you, or even people who look like you or who were like you just a few years ago who have done better. Countries like, there are lots of countries like in Latin America which have similar systems as ours, which are getting better. if we learn from those systems, instead of trying to learn from international systems and thinking, oh, I have to be like the UK system, I have to be like this system, our benchmarks will keep failing. So regional partnerships and learning from people who with similar experiences as us. And I think the next one that I'll talk about is stop treating healthcare as this one is, I don't know how I can even put it. It's a national strategy. It's not just a health strategy. And this is one thing where health also faces a challenge. In a country with a limited budget, where 80% of healthcare spending is out of pocket, when it comes to public health, if the Minister of Finance or the government doesn't prioritize health, even the Ministry of Health cannot prioritize health. Money is where the power is. So when it's about advocating not just as a minister to, okay, I'm managing health, but advocating to your own country's government and the structure and showing where the benefit of investing in health is. Because someone said it and it's true, our countries have limited money. And when you have limited money, it's like in your house, when you have 10,000 francs, you prioritize what you need first. And if there's someone coming and saying, oh, I'll buy you free food, you can use that money on electricity. Of course, you will take it. There's nothing wrong with receiving aid. Aid is not the problem. So when we talk about sustainability and saying, oh, we need to drive out all aid, we need to cut off aid, that's not where the sustainability for me comes in. So sustainability in aid is trying to find our own avenues of power. Where in this relationship, if you're bringing the money, what am I bringing? And put that on the table. Don't come to the table as if you're a beggar. You might not be bringing money, but you're bringing other things. You're bringing resources. You're bringing expertise. You're bringing this. You're bringing that. So we should like leverage our negotiations when it comes to donor relationships. We should not come as beggars to the table. And at the last one, I would say research. And let's really stop doing research that is, I'm not a pure researcher. I did a bit of preclinical research and I gave up on that. But my call to the researchers here, let's stop. It's a naive call, but I'm still making it. Let's not stop, but let's also do research that is pertinent to our needs. Because there are research that are global trends. You know that if you publish on this topic, tomorrow it will reach this paper. Tomorrow it will be on the Lancet. But is it relevant to the problem you're trying to speak on? So don't be a researcher that is the same thing with even us who work in the NGO space when you're applying for grants. Don't be applying for the grants just because of the money. Money is important. Do an evaluation of, if I get this money, how does it match the initial need I had tried to solve in the first place? There's a way you can win on both terms. You just have to be smart about the work that you're doing. But for a lot of us, we follow the trend of which is the most current topic of research right now. That's what I'm doing. I don't care if my initial interest in research was this, or I'm not even going to look for someone who's interested in my research. I'll focus on which is the one that is trending. And it might not be relevant to your country, it might not be relevant to your community. So try and find the balance. Obviously, you need money for research, but you also need to focus on the needs. And the truth is that there are people who have stood their ground in research by focusing on what is important, and they've gotten the results for it. I think there's this South African researcher, Professor Salim, I love him, Salim Abdul, who talked about the fact that during COVID, he and his research team were the first to discover the Omicron variant. By that time, the world had already been like, oh, we're done with COVID, we're moving on. So even the fact that he was still focused on COVID was not a trendy topic at that time. And overnight, they called him to have that published in the Lancet, and everyone was calling him like, how did you find this? How did you monitor that? But it was nothing of interest to anyone. He just decided that was something that he saw relevant to his country, and he saw the uptake of cases, and he was like, what's happening here? We need to find out what's happening. So those are my 3 calls. Follow the research with the interest, even though you need the money. Come to the negotiating table with something. And sometimes that thing can be money. If you're coming to a donor and you're saying, I'm putting 1 million on this and I need you to put 10 million, it's something. You can't come to a donor and say, I have nothing, I have 0, and I want you to give me the 10 million. Then it becomes a begging situation. That's what is happening to us. We receive products, we don't even have the money to carry them from the port to our offices. That's not a relationship. And the first one, I've forgotten what I said. I've been rambling, but thank you.
Thanks a lot, Fatima. Just because we're running short on time, just final, maybe your question, Dr. Mono, and then we would like to hear some closing thoughts from you, Dr. Mono. Over to you.
Yeah, I would like to start with my question. This session, I didn't want to ask a question, but I will, in public health, apart from being maybe an internist and an oncologist and also a pathologist, but I'm a very avid public health advocate. In public health, we say, it's just an old saying, he who pays the piper actually calls the tune. And if you don't know that, the golden rule is actually he who has the gold makes the rules. So we need to start deciding if we're going to own the gold and make rules or not. It drives every basic policy that we actually finance. So research, as Fatima has said, is super important, but we should learn. Brian knows I'm an advocate of this, and I'm a big fan of talking about how I despise research done for research's sake. You need to publish one paper that's going to change the world and stop publishing 100 papers that will make no sense. So research should be driven for local policy changes. Cameroonians should do research that they're based on changing their local policies and advocating. That goes to our topic here. And carry out clinical trials and all of that. Those are just things I wanted to add. But my questions go into look at, do we do need assessment, Fatima? I'm going to ask a series of questions. Do we do need assessment at the local levels where you guys are? Are there tools that you are able? I worked in Cameroon at the district level. I've been a district medical officer. I've been multiple things. But do you do need assessment at the local levels in order to drive how we advocate different drugs, or how we do chain supplies? Do we do that? That's my first question. My second question is just one thing, trying to understand the job of each of them. I know I've always been a big guy trying to understand what Sename really does. Like, Sename is actually the National Center for Procurement and Supply of Essential Medication. Does Sename really work with LANACOM, which is the National Drug Quality Control and Evaluation Laboratory? And what is the capacity? Who tells LANACOM to test what medication? Does Sename work with LANACOM and tell them, test this? How many percentage of medications are tested in Cameroon? I have been a big interest of trying to understand this, how it works. Do we just trust everybody? Do we choose to test ones that we don't trust from donors we don't trust, or do we test at all? I know you're a pharmacist and you did rotation in all these places. I just want to get your input about these few things before I would say my conclusions, Brian.
Thank you.
Thank you. Yeah, drug regulation was a particular interest of mine. I thought that was what I was going to do when I left school, so I'm passionate about that. About needs assessment, yes, there is a lot of needs assessment done. I can say that for public health programs. Now for essential medicines, it's a different route. For public health programs, most of them are paid for by the donors themselves, who are going to be the ones buying the product. So usually there's a whole pathway. It takes like a 3-year process. They say, okay, we are agreeing that we're buying medications for this. Let's start with a survey. It's usually administered in selected health facilities and selected regions. They have a sampling. They usually hire either consultants or use the regional teams to do these surveys. I think I've done one for sexual reproductive health or so. And this data is compiled and used. But for essential medicines, what they have is what we call a National Drug Selection Committee. What they do is that they have a representative sample of people from districts, small hospitals, regional hospitals, reference hospitals, ministries, and they sit down. I think it's usually every 2 years or so to revise the essential drug list. And so their logic is that these experts who represent all of this strata of the healthcare system have to come in with evidence representing their strata. And they compile this evidence based on, okay, what are the new clinical procedures? What are the WHO recommendations? What are you seeing on the field? And come up with things like this. But I'll have to say, for example, the National Drug Selection Committee, there was a time when it spent almost 5 years and that committee didn't sit. And so there were a lot of backlog of medication that were waiting to get approval, to get into the country, or even to be taken off the list of medications because their approval had expired in other countries, which were not taken off. But I do know that it held 2021, and I think the most recent should have been 2023 to hold. Now, the last one, Sename and LANACOM, interesting combo. So normally, there is a memorandum of understanding between Sename and Lanacom around testing. I worked for Lanacom around 3 to 6 months, and I have to say there was a limited amount of product that is. It's a memorandum of understanding, but each of those structures operate as individuals, which means Sename has to pay Lanacom for testing. And if Sename has been known to have backlogs with their international suppliers, you obviously know they have backlogs of payment with Lanacom. And Lanacom says, if you don't pay me for the testing, I can't run. I'm a public structure. I have to demonstrate my accounts. I have to prove my expenditures. So there were times like that when those lots of products will not work. But now what the DPML or the Department of Pharmacy usually does for international imports is that you have international certificates of conformity where they trust the fact that if this product was validated by the FDA or if it was validated by some other agency that I have vetted, then I'll allow, as long as you can demonstrate that certificate to me and you bring your documents that were validated by the FDA, I can allow you in. So a lot of products have that route where you don't need to be fully tested because we don't have the capacity to fully test. But I'm also happy to say that besides Lanacom, there are a lot of other drug evaluation laboratories. I wish my colleague from the PCC was here. The Presbyterian Health Services actually has a good one in Limbe because they also have their drug house, the PCC Drug Services, which is a large warehouse in Limbe where they're allowed to do their own procurement for products that go to all their health facilities. So they have a mini lab and there are other, I don't know if there's another person in Cameroon. There should be one other organization in Cameroon that has that. And that's a way that people can pick up from the slack of the government. For example, if you're the PCC and you're doing direct imports, you have authorization from the government to do your own imports, then you can test your own products. And you'll be allowed to know that a lot of the drug recalls that have been made in the country, the PCC has contributed to more than 50% of those drug recall notes. They're the ones who did the testing and then send the information to the national level and then the drugs were recalled. So, yeah.
Yeah, thanks a lot. Thanks a lot. And also thanks to everyone. We have a parking lot immediately at the end of this session. We can continue the discussion. I know there are lots of people on this call who have appointments in the minister and there are people who would not want to talk because they are being on record. But yeah, so we have a parking lot after this. But I just wanted to thank you. Thank you so much, Dr. Fatima, for this really insightful discussion today on a very, very critical topic. I think it's very clear from the experiences shared that supply chain management challenges permeate all levels of Cameroon's healthcare system, from the systemic issues that we talked about to on the ground challenges that really require urgent solutions. So there are no solutions. There are no simple solutions to this problem, but at least having an initial and open dialogue of some of these challenges and engaging stakeholders, I think is an important first step. So thanks a lot for helping us get those conversations started. So with that said, I just want to turn on to Dr. Mono, the chair of the town hall, for his closing remarks. Dr. Mono.
Wow, Brian, thank you very much. And I'd just like to thank Dr. Fatima for the wonderful presentation and discussions that we have had so far concerning supply chain management, which it's a topic I've learned a lot. And there have been a lot of solutions that have been proposed. We have also discussed limitations that we have back home, including research, which we did talk about clinical trials. We talked about issues with manufacturing, pharmacovigilance. We did talk about supply chain managers being trained, which I think that was a big take-home message for me, that not all pharmacists can do the job of supply chain management. We need to work hand in glove in order to develop things. We all know we have a big problem with governance back home in Africa, which is something that needs a system change. And we need to be able to do better need assessments and prevent donor dumping. So one of my take-home messages usually is always for us as Africans to be able to invest in healthcare. Donors are important, but we need to start investing our money where our mouths are, where we talk. As I said before, in the matter of finance, power lies with the one who holds the wallet. If you hold the wallet, you decide what your goals are, what you want others to do. So I think we should start investing in healthcare as much as the Abuja Declaration, get ourselves at least at 15% of our GDP. That would be great. So, and I just want to thank Dr. Fatima and for the 4 years or 3.5 years she's been on the platform, and for the wonderful presentation. We would want her back. She talks, she has multiple advocacy things that she does, so we're ready to invite her back sometime in the future, and also inviting her to join us. And I know Dr. Fockham is not here. It will be important for us to get Dr. Fockham to come into the town hall. He's now the new Secretary General of the CNLS, which is the Comité National de Lutte contre le Sida. I controlled that organization in Bamenda for like 6 months. I was in charge for like 6 months. So before I was sent over as director of a district hospital, I was in charge of that organization for 6 months. So in the Northwest region, it's very important that we have these leaders come over here and tell us exactly what their goals are, because each organization with a change in leadership comes in with new ideas. And Dr. Fockham has been involved in a lot of clinical research back home in HIV and other infectious diseases. I think he's the right person to lead this train going forward. So Brian, thank you for giving me the floor, and over to you.
Thank you. And some final thoughts from you, Dr. Fatima, please.
I have spoken quite a bit. This is 2 hours of me talking. But thank you all. It was a pleasure, and the level of interest. I told Brian before this that I thought supply chain was quite a boring topic, and a lot of people will have nothing to say about it, but you've proven me wrong. So it was a pleasure to share with you, and I'm available to keep the conversation going outside of this platform. You can reach out to me. I should probably just drop my email in the chat. And yeah, thank you all.
Yeah, thanks.